Microcirculation. Welcome to this next lecture in the circulation series on microcirculation. My name is Valerie and I will be here to take you through this lecture. Learning objectives. So, by the end of this lecture, you should be able to identify the primary mechanisms of capillary exchange, understand the difference between hydrostatic pressure and blood colloid osmotic pressure, understand the concept of net filtration pressure, and be able to compare and contrast filtration with reabsorption. Okay, so personally, it took me a long time, like literally, not on the MCAT, not really even on my USMLE Step 1 did I quite understand this concept until I started doing my clinical rotations. So a lot of people told me this was an easy concept, but for some reason for me it just never clicked. But now I understand it, and I am going to try to make this as easy as I can for you. So just stick with me here. And if you feel like you're not getting it and you have to go through it a few times, don't feel bad. It's just kind of that kind of concept. So, the primary purpose of the cardiovascular system is to circulate gases, nutrients, wastes, and other substances to and from the cells of the body. Small molecules, such as gases, lipids, and lipid-soluble molecules, can diffuse directly through the membranes of the endothelial cells of the capillary walls. Glucose, amino acids, and ions, including sodium and potassium, calcium and chloride, are going to use transporters to move through specific channels in the membrane by facilitated diffusion. Glucose ions and larger molecules may also leave the blood through the intercellular clefts. Larger molecules can pass through the pores of fenestrated capillaries, and even large plasma proteins can pass through these gaps because they are so great in the sinusoids. Some large proteins in the blood plasma can move into and out of the endothelial cells packaged within vesicles via endocytosis and exocytosis. However, water will always move by osmosis. So, the mass movement of fluids into and out of the capillary beds is going to require a transport mechanism far more efficient than mere diffusion. The movement, often referred to as bulk flow, involves two pressure-driven mechanisms. One is volume of fluid move from an area of high pressure in a capillary bed to an area of lower pressure in the tissues via filtration. So the first mechanism is going to still be pressure-driven, but it's filtration. And the second mechanism is also pressure-driven, and it's reabsorption. So, in contrast to filtration, the movement of fluid from an area of higher pressure in the tissues into an area of lower pressure in the capillaries is going to be reabsorption. So these two types of pressures interact to drive each of these movements, hydrostatic pressure and osmotic pressure. So, hydrostatic pressure. Hydrostatic pressure is the primary force driving fluid transportation between the capillaries and tissues. So, hydrostatic pressure can be defined as the pressure of any fluid enclosed in a space. So we're going to have blood hydrostatic pressure and capillary hydrostatic pressure. So blood hydrostatic pressure is the force exerted by the blood confined within the blood or the blood vessels, or the heart chambers. So even more specifically, the pressure exerted by the blood against the wall of a capillary is going to be called the capillary hydrostatic pressure, and it's going to be the same as the capillary blood pressure. So the capillary hydrostatic pressure is going to be the force that drives fluid out of the capillaries and into the tissues. So as fluid exits a capillary and moves into the tissues, the hydrostatic pressure in the interstitial fluid correspondingly is going to rise. This opposing hydrostatic pressure is called the interstitial fluid hydrostatic pressure, or interstitial hydrostatic pressure. So generally, the capillary hydrostatic pressure originating from the arterial pathways, or the blood hydrostatic pressure, is going to be considerably higher than the interstitial hydrostatic pressure because the lymphatic vessels are continuously absorbing excess fluid from the tissues. Remember, the lymph is taking out all the garbage. So, fluid generally moves out of the capillary and into the interstitial fluid, and this process is called filtration. Now let's talk about osmotic pressure. Osmotic pressure, before we say anything, I want you guys to remember that osmotic pressure is always driven by protein concentration. No matter if it's the blood osmotic pressure, the interstitial osmotic pressure, any oncotic pressure is going to be driven by protein concentration in whichever fluid it is home to. So, osmotic pressure, the net pressure that drives reabsorption, or the movement of fluid from the interstitial fluid back into the capillaries, is going to be the osmotic pressure, or oncotic pressure. I was previously just saying oncotic pressure because that's the term I'm familiar with, but osmotic pressure and oncotic pressure, they're interchangeable. And for me, probably I'm going to keep saying oncotic pressure unless I read it somewhere and accidentally call it osmotic pressure. But they are interchangeable, they are the same thing. Don't be put off, don't be confused. So, we know that the hydrostatic pressure forces fluid out of the capillary, but osmotic pressure or oncotic pressure is going to pull that fluid back in. So, oncotic pressure is determined by the osmotic concentration gradient. That is going to be the difference in the solute to water concentrations in the blood and the tissues, aka the protein concentration. Oncotic pressure is driven by protein concentration. Remember that. A region higher in solute concentration and lower in water concentration is going to draw water across the membrane from a region of higher water concentration and lower solute concentration. So as we continue discussing oncotic pressure in the blood and the interstitial tissues, it's going to be important to understand the elements of the blood. So the formed elements of blood do not contribute to the osmotic concentration gradient. It's not all of that stuff. All that is going to contribute to the concentration gradient of oncotic pressure is going to be these proteins, plasma proteins. These are the key components. So solutes also move across the capillary wall according to their concentration gradient. But overall, the main players here are the plasma proteins, and the concentration should be similar between both sides of the membrane or the capillary wall, so it does not have a significant impact on osmosis of water. So because of their large size and chemical structure, plasma proteins are not truly solutes, so they don't dissolve, but instead they are dispersed or surrounded in the fluid medium, forming a colloid rather than a solution. So the pressure created by the concentration of colloidal proteins in the blood, aka the plasma proteins, is going to be called the blood colloidal osmotic or oncotic pressure. So the blood oncotic pressure has an effect on capillary exchange, and its effect on capillary exchange is going to account for the reabsorption of water. So the plasma protein suspended in blood cannot move across the membrane of the capillary cell wall, and so they're locked, they're stuck in the plasma. And as a result, blood is going to have a higher colloidal concentration and lower water concentration than the tissue fluid. It, therefore, is going to attract water. So another observation or fact that we can observe is going to be that the blood oncotic pressure is always or almost always going to be higher than the interstitial colloid oncotic pressure, because the interstitial colloidal oncotic pressure is almost always super low because the interstitial fluid contains very few proteins, and as we said before, proteins are too large to readily diffuse across the membrane. So, water is going to be drawn from the tissue fluid back into the capillary, carrying dissolved molecules with it. The difference in colloidal oncotic pressure is going to account for reabsorption. So, oncotic pressure, we're thinking favors reabsorption, we're thinking influenced by proteins. For hydrostatic pressure, we're thinking about filtration, and that's the name of the game. So I just went into heavy detail on this stuff in the last slide, but this is a really good summary slide. So in the next two slides, we're going to go through hydrostatic pressure and the oncotic or osmotic pressure. So remember, these are like a push and pull kind of situation. So we have two forms of hydrostatic pressure and two forms of oncotic pressure. So our two forms of hydrostatic pressure are going to be the capillary hydrostatic pressure and the interstitial hydrostatic pressure. So, 1 second. Okay, so capillary hydrostatic pressure and interstitial hydrostatic pressure. So for the sake of keeping everything the same, basically hydrostatic pressure is always symbolized by the P, and as you'll see on the next slide, osmotic or oncotic pressure is always symbolized by the pi sign. I'm not sure why that is. I kind of personally thought it was confusing, but that's just how it is. So PC and PI are going to be capillary hydrostatic pressure and interstitial hydrostatic pressure. So, now that that's out of the way, capillary hydrostatic pressure, when capillary hydrostatic pressure is increased, remember, it's going to favor filtration out of the capillary and into the interstitial space. So, capillary hydrostatic pressure is favoring filtration. So if we have increased capillary hydrostatic pressure, we're going to have increased filtration. So capillary hydrostatic pressure is determined by arterial venous pressures and arterial venous resistance. So capillary hydrostatic pressure is going to be higher at the arteriolar end of the capillary than at the venous end because the arterioles are going to have a higher pressure and resistance than the veins. The interstitial hydrostatic pressure is going to oppose filtration out of the capillary, which could also be kind of reworded to say that it's going to favor reabsorption. So interstitial hydrostatic pressure, if that increases, then anti-filtration will happen basically, or it's going to oppose filtration out of the capillary. But the caveat is this is normally close to zero, and a lot of times it's irrelevant. So just a quick recap. When we talk about hydrostatic pressure, we're talking about filtration. Somebody's for filtration and somebody's against filtration. So the capillary hydrostatic pressure is going to favor getting that extra fluid out of the capillary and into the interstitial space. So I think also it's important that we understand the definitions of filtration and reabsorption. So I think it's easier if you know that reabsorption means that we're reabsorbing back into the blood or the capillaries. So if you know that reabsorption is into the blood or capillaries, then filtration is going to be the opposite. So filtration is going to be out of the capillaries and reabsorption is into the capillaries. Filtration is out of the blood and reabsorption is into the blood. So oncotic or osmotic pressure, as I said, it's symbolized by the pi sign. So pi C is going to be capillary oncotic pressure and pi I is interstitial oncotic pressure. So basically, we already said that oncotic is going to be pulling and pushing back and forth between reabsorption, and reabsorption means reabsorbing blood or filtrate or whatever it is back into the capillaries, back into the blood, and that oncotic pressure or osmotic pressure is going to be dictated by protein concentration. And hydrostatic pressure, just to reiterate, is going to push and pull with filtration, and filtration is taking that stuff out of the capillaries or blood and back into the interstitial space. So, capillary oncotic pressure is going to oppose filtration. So the higher or more capillary oncotic pressure we have, the more we're going to oppose filtration. So capillary oncotic pressure is increased by increased protein concentration in the blood. So when do we have increased protein concentration in the blood? Usually just with dehydration. I can't think of anything else off the top of my head, but the dehydration concept works because we are literally having less fluid in the blood, so therefore by just as a consequence, if we have less solution, there's going to be an increased amount of proteins because the protein concentration is actually unchanged. So also, capillary oncotic pressure is decreased by decreases in protein concentration in the blood, which makes sense. It's just the same concept except reversed. So what are some things that are going to decrease protein concentration in the blood? Well, we have nephrotic syndrome, which is where the kidneys are losing extra protein because there's a problem with the glomerular barrier. And we're peeing out a lot of protein in nephrotic syndrome. So since we're losing all of that protein in the urine, there's less protein in the blood. With liver failure, the liver actually makes a lot of proteins that are released into the blood. Proteins for inflammation, proteins for clotting, proteins for everything. So if the liver is failing, then they're not making those proteins, and therefore there's less proteins in the blood. Capillary oncotic pressure is going to decrease. So interstitial oncotic pressure. Interstitial oncotic pressure is going to favor filtration out of the capillary. So if we have an increase in interstitial oncotic pressure, we are going to have increased filtration out of the capillary. And basically, interstitial oncotic pressure is going to be dependent on the protein concentration in the interstitial fluid. So remember, oncotic pressure is always going to be dictated by the protein concentration in whatever fluid it's named after, meaning capillary oncotic pressure is going to be determined by the protein concentration in the capillary or in the blood, and interstitial oncotic pressure is going to be dictated by the protein concentration in the interstitial fluid. And also remember, hydrostatic pressure is playing with filtration and oncotic pressure is playing with reabsorption. So this slide is just going to review some factors that increase filtration and go over a little bit about how hydrostatic and osmotic pressures interact. So what are some things that are going to increase filtration and what is that going to result in? So if we have increased filtration, we have increased excretion of fluid out of the capillary and into the interstitial fluid. So remember that that's connected to our lymph, and basically that's going to lead to edema. So edema is just swelling. So some factors that increase filtration are an increase in hydrostatic capillary pressure, decrease in hydrostatic interstitial pressure, a decrease in oncotic capillary pressure, and an increase in oncotic interstitial pressure. Notice that the factors that increase filtration are opposing each other. For instance, the capillary hydrostatic pressure will be increased, but the oncotic capillary pressure will be decreased, and the same with the interstitial pressure. If a decreased hydrostatic interstitial pressure is going to favor filtration, then an increase in oncotic interstitial pressure is going to also favor filtration, because remember, it's the whole push and pull concept. These factors are opposing each other. So an increased hydrostatic capillary pressure could be caused by an increased arterial pressure, increased venous pressure, increased arterial dilation, or from venous constriction. A decrease in capillary oncotic pressure could be caused by decreased protein concentration in the blood. We already discussed this. And also what we didn't really talk about was that an increase in oncotic interstitial pressure could be caused by inadequate lymphatic function. The net filtration pressure represents the interaction of the hydrostatic and osmotic or oncotic pressures, driving fluid out of the capillary. It is equal to the difference between the capillary hydrostatic pressure and the blood colloid osmotic or oncotic pressure. Since filtration is, by definition, the movement of fluid out of the capillary when reabsorption is occurring, the net filtration pressure is going to be a negative number. Net filtration pressure changes at different points in a capillary bed. Close to the arterial end of a capillary, the net filtration pressure is approximately 10. Because the capillary hydrostatic pressure of 35 millimeters of mercury minus the blood colloid oncotic pressure of 25 millimeters of mercury equals 10. So recall that the hydrostatic pressure and the osmotic pressures of the interstitial fluid are essentially negligible. Thus, the net filtration pressure of 10 drives a net movement of fluid out of the capillary end. At approximately the middle of the capillary hydrostatic pressure is about the same as the blood osmotic pressure of 25. So the net filtration pressure is going to drop to 0. At this point, there's no net change of volume. Fluid is going to move out of the capillary at the same rate as it moves into the capillary. So remember, this is in the middle now. So before, where at the arterial end, where the net filtration pressure was about 10, and that was at the arterial end. And now, as we move to the middle, we've kind of hit an impasse. It's equal. The pressure is about 0, and so this slide just basically summarizes everything I talked about in the previous slide, but now we have a visual. So let's talk more about this capillary exchange that we've been talking about. We said that it's important to understand the difference between filtration and absorption or reabsorption. So filtration is going to be positive net movement of fluid out of the capillary and into the interstitium. And reabsorption is going to be the net movement of fluid into the capillary and out of the interstitium. So reabsorption, the way I always think of it, like these two are opposites, right? So if you know that reabsorption is back into the blood, then filtration has to be into the interstitial space. So when I say it as a phrase, when I was first learning it, I would always say reabsorption into the blood, so that this way, that's the phrase, you can't forget it. So, excess filtered fluid is returned into the circulation via lymph. Lymph is going to also return any filtered protein back into the circulation. Ultimately, we have a whole lecture about lymph and all of that stuff, but just so you have a general idea, the lymph is ultimately going to drain into, from most of the body anyway, into the thoracic duct, which will go into the superior vena cava, and that obviously drains right into the right atrium. So that's basically how the lymph meets the blood. So I hope this lecture wasn't too complicated. That's really all just a bunch of push and pull mechanisms. Which one has filtration, which one works on reabsorption, what is filtration, what is reabsorption. These are all things I hope you understand at this point, and thanks for sticking with me through this lecture.